المؤمنين ويبشر المؤمنين الذين يعملون الصالحات أن لهم أجرا حسنا ماكثين فيه أبدا وينذر الذين قال اتخذ الله ولدا ما لهم به من علم ولا لآبائهم كبرت كلمة تخرج من أفواههم وإن يقولون إلا كذبا فلعلك باخع نفسك على آثارهم وإن لم يؤمنوا بهذا الحديث أسفا صدق अल्लाहुल अज़ीम। ये सूरह काफ की इब्तदाई आयत हैं जो मैंने तिलावत की हैं। अल्लाह रब्बुल इज़्ज़त पहले तो नबी पाक सल्लल्लाहु अलैहि वसल्लम की तरफ से हम्द का बयान है कि उनको अल्लाह ने ऐसी किताब अता फ़रमाई कि जिसमें कोई कजी और कोई टेढ़ नहीं है। और फिर अल्लाह रब्बुल इज़्ज़त फरमा रहे हैं कि बहुत बड़ा कलमा है जो ये अपने मुंह से निकालते हैं, जो ये मेरे साथ शिर्क करते हैं और ईसा अलैहिस्सलाम को जो मेरा बेटा बनाते हैं, तो ये बहुत गुनाह की बात है जो इनके मुंह से निकलती है और ये सरीहन झूठ है और ना ही इनके पास इसका कोई सनद भी इनके पास इसकी नहीं है। और फिर अपने प्यारे रसूल सल्लल्लाहु अलैहि वसल्लम से खिताब करते हुए फरमाते हैं, जिसका मफ़हूम है कि ऐ नबी, आप अपने आप को इनके पीछे हलाक कर डालेंगे कि ये कबूल नहीं कर रहे। और इसी के रुकू के आखिर में फिर जो इस सूरत का अमूद है, जो उसका मरकज़ी मज़मून है, जो मैंने तिलावत नहीं किया, वो है कि ये दुनिया जो हमने इसकी ज़ीनत बनाई है ये आर्जी है और हम इसको बहुत जल्द तोड़ फोड़ कर बराबर कर देने वाले हैं। तो इसमें अपना दिल मत लगाओ, इसके अंदर रहते हुए हमारे हुक्मों पर अमल करो और ये मौका तुम्हें इसलिए दिया है कि तुम अपने आप को मेरा बंदा साबित करो। उसके बाद मैं तुम्हें हकीकी रिवार्ड अता फ़रमाऊँगा और वो हमेशा रहने वाली दुनिया में तुम्हें एज़ाज़ व इकराम के साथ अपने बंदों में शामिल फरमाऊँगा। जैसे वो फरमाते हैं, या अय्युहन नफ्सुल मुतमइन्ना इरजी इला रब्बिकी राज़ियतम मर्दिया फदखुली इबादी वदखुली जन्नती। तो कहने को तो दुनिया में हम सब अल्लाह के बंदे हैं, लेकिन अल्लाह रब्बुल इज़्ज़त एक इनाम के तौर पर क़यामत के दिन इरशाद फरमा रहे हैं, जिसकी नक्शा कशी कुरान में यूँ करते हैं कि ऐ मुतमिन रूह, अब दाखिल हो जा इस जन्नत में और मेरे बंदों में दाखिल हो जा और इस जन्नत में दाखिल हो जा। यानी जो हकीकी बंदे हैं वो होंगे जिनको अल्लाह रब्बुल इज़्ज़त रोज़े क़यामत को ये सनद अता फ़रमाएंगे कि ये हैं मेरे बंदे और इनके लिए है रिवार्ड। तो अल्लाह रब्बुल इज़्ज़त हमें मरने से पहले मरने की तैयारी करने की तौफ़ीक़ अता फ़रमाए और अपनी ज़िंदगियों को इस अंदाज़ में गुजारने की तौफ़ीक़ अता फ़रमाए कि जब हमारा दुनिया से जाने का वक्त आए तो हमारी रूहें कब्ज़ करने के लिए वो फ़रिश्ते आएँ जो अल्लाह के नेक बंदों को रूहों को लेने के लिए आते हैं। व आखिरु दावाना अनिल हम्दुलिल्लाहि रब्बिल आलमीन। तो इसके साथ ही माइक प्रोफेसर मजीद मलिक साहब की तरफ जाता है।
ज़ाकल्लाह। Thank you, Madir Sahab, for bring up an excellent introduction to the session with Tilawat Pak. Now let us start with the session. Luckily, we had a very good session before that, great debate on cataract surgery, step-by-step complications and their management. It was a houseful session. Hopefully, it will be houseful after a while because people have gone for a tea break. Now I will request my most respected and honorable Professor Nadeem Riaz to be pioneer in the session by telling about mastering capsular axis. Professor Nadeem Riaz.
Bismillahirrahmanirrahim. Thank you very much, Malik Bhai. My topic is mastering capsular axis. It is such a huge subject that I think I can spend at least a week on this subject, but I have to do it within the very constraint of 5 minutes here. So there are certain prerequisites for a good CCC. There should be a clear cornea and well-maintained deep anterior chamber, good quality viscoelastics so that you can keep the depth. There should be a very good cystotome. I prefer a needle one which I can customize according to my needs. Pupil should be well dilated. And what I think is that, with the needle cystotome, one has a very good control on the size and the configuration of the capsular rexes, because that ultimately determines the proper centration of the IOL, and proper overlapping of the anterior capsule over the lens to prevent PCO later on. But there are certain situations when it is not possible, then you have to really stay in the capsule. And the other added problem is that the cataract is swollen, it's intumescent. So it is pushing everything forwards, and the direction of the vector is centrifugal rather than centripetal. So there's always a tendency for the rexes to kind of run off. So you have to counter that force by keeping your pressure the lowest and keeping the chamber deep. Sometimes you have to resort to the capsular rexis forceps, the Utrata forceps, to kind of avoid a runoff. Here you would see that there is a tendency, constant tendency for the capsule to go underneath the iris, but you have to counter these forces. So this is how I would do, and make sure that you don't press on the posterior lip of the wound so that the viscoelastic, the OVD, stays within the anterior chamber. Similarly, when there is too much of pressure within the intralenticular pressure is very high, then you have to decompress this in order to, because if you don't do that, with the first puncture, the whole thing would just finish, and Argentinian flag sign would appear, whereby there's a rupture of the rexes, and it just goes beyond your control. So once you decompress the intumescent cataract, then things become pretty under your control, as I'm doing here. You would see still there is a problem, because the cataract has really become a fluid. There's hardly any base to work on, so that's why you have to counter so many forces working against your maneuver. So here there's a intumescent cataract, and it is making your life difficult. But if you're patient, if you follow the rules of deep anterior chamber, proper filling of the anterior chamber, and do not press on the posterior lip of the incision, then things would be very much favorable for you. So here I have been able to successfully complete the rexes. I wouldn't have been surprised if it just runs off beyond my control. So these are little tips. Somebody was just asking me what to do with the intumescent cataract. So this is really a very good way of avoiding a runoff and proper capsular rexes.
Sir, may I ask
Please.
your opinion?
Yes, yes.
Do you use injection mannitol in such intumescent cataracts?
Yes,
sometimes?
I do. Yes, I do. But only in intumescent cataracts. It is not required every time. Simple 2 tablets of acetazolamide also do the trick. But if the cataract is very swollen and you're terrified of having a runoff, then it's better to lower the pressure as much as possible. It does help, definitely. Thank you very much.
Thank you, Professor Nadeem Riaz Sahab, enlightening us with mastering of capsular rexis techniques. तो हमारे उस्तादुल असातीज़ अपने तजर्बे से और अपनी स्लो मोशन टेक्निक से हमें मुस्तफ़ीद कर रहे थे. तो सर वासिफ़ साहब के एसोसिएट रहे हैं, तो सर को देख के वासिफ़ साहब की याद आ जाती है, क्योंकि धीमा धीमा अंदाज़ सर्जरी का और धीमा धीमा अंदाज़ चलने का प्रोफेसर वासिफ़ मोहिउद्दीन क़ादरी रहमतुल्लाह अलैह से बहुत मिलता है, और हमें इन दोनों शख्सियतों की शफ़क़त हासिल रही है अल्हम्दुलिल्लाह. तो अब हम वी रिक्वेस्ट प्रोफेसर मजीद मलिक साहब, pivot of Pakistan Association of Cataract and Refractive Surgery. He is gum of our society. He keeps it all of us together, and he is here with his talk. on capsular axis in soft milky cataract and hydro IOL implantation. Professor Majid Malik.
Thank you, Mazari Saab, for your kind words. And thank you, Professor Dimriaz, for an excellent presentation on the subject. There are so many of you, but we could not get advantage of many because of time constraints. So, again it is the same, how to manage milky cataract plus how to implant an IOL at the end of surgery in a station or working place where you have high volume surgery. So in this case, side port, preferably 2. Fill it. No, I didn't do the same. I just made a curved incision and a very superficial incision without reaching the cortical matter. Just capsule touch. And luckily, thing went okay. So that is, if you don't touch the capsule, milky matter will not come out. And if it does, then the technique should change according to Professor Nadeem Riaz. Now, hydrate and lift, it is known as hat. Hold and tilt technique. How to dissect it? Mobilize it, and then you should be sure that it is fully mobilized nucleus and lens. Now you are lifting it by visco. It takes only 5 minutes for the entire surgery, right from the start till implantation of the lens. There is no editing in this case. It is complete surgery. Just this, you held it. Remove the soft lens matter from the top. Hold the nucleus. As Dr. Sharaf was asking, this hold, tilt and go back, and here make a cut and divide it into 2 pieces. You don't need it to make multiple chops. Keep it behind and keep on removing them. If it is, sometimes it divides into 2 immediately, but sometimes it takes another cut, as in this case. Just everything is done. Minimal visco in first place, no visco after that, and probably there will be no viscoelastic injection, because in this, after removing the visco, still you have chance to have a retention of visco and there is pressure. Now Simco will come in action to take out the lens matter. The last step will be IOL implantation, hydro IOL implantation, in which it will be without viscoelastic. So almost done with the cortex from one side. So done. Now, after washing it, cleaning the capsule, a bit of polishing with the Simco cannula. By the time the assistant has loaded the lens, just place Simco with hydration and fill the IOL without adding any visco, and then dial just with the help of your Simco. You have not done anything much. Clear the lens matter Lens method, no, it will clear the visco that had gone along with the IOL implant. And job is done. It is known as hold and tilt technique and hydro implantation of the intraocular lens. Quick surgery, 5 minutes, maximum time 5 to 6 minutes, and that's it. Hydrate. Within the bag. Because of high volume surgery, we make the relaxation a bit larger than normal, 6 millimeter or so in these cases. Vertical chopper. Even sometimes dialer works. Dialer can work.
ये जो चॉपर्स और उनकी जो कॉन्फ़िगरेशंस और कॉस्मेटिक्स हैं उसमें हम बहुत ज़्यादा नहीं पढ़ते, हम तो मज़दूर लोग हैं, वहाँ पे जो भी सेकंड इंस्ट्रूमेंट वो पकड़ा देते हैं उसी से काम चलाते हैं, वही चॉपर के तौर पर एक्ट करता है, उसी से लेंस को डायल करते हैं।
खत्म कर दो
बजाय आइडियल तो अच्छी बात है, वो तो कई किस्म के हैं, साइबल्स एंड व्हाटएवर।
थैंक यू वेरी मच। ये दोबारा रिपीटिशन हो रही है।
तो चॉपर की टाइप से ज़्यादा इस इंटेलिजेंट यूज इज़ वेरी इंपॉर्टेंट। इट हैज़ टू बी ऑफ एन एडिक्वेट साइज, जस्ट अ लिटिल, द बेंड शुड बी अ लिटिल मोर देन द डायलर, and it has to be well polished and round in the end, then you can use it. If the tip is very little, it's difficult to manipulate the nucleus with it. So if we get an in-between instrument between a very long kind of tip and a very short dialer kind of tip, if we get in between, it can be used for all the purposes. And if we are alhamdulillah rich in resources and we have different choppers available, you are welcome to use that as well. Is there any other comment about this video? Chalein sir, agla bulwa lein.
No. Next presenter is Dr. Khalid Mahmood, probably not there.
Ijazuti sawana chal.
उनको बुलाते हैं अभी। आपने जाना वापस? Professor Ijaz Latif had to go to Bahalpur, so I will request him to be on the dais. Managing soft cataracts, 1, and handling difficult cataracts with capsular dehiscence. ये साउथ पंजाब के बड़े रिनाउंड प्रोफेसर हैं और बड़े हाई क्वालिटी सर्जरी है इनका सेंटर भी बड़ा खूबसूरत है। इट इज़ नॉट ओनली एन आई सेंटर, इट इज़ एन आर्टिस्टिक सॉर्ट ऑफ बिल्डिंग from within and from without.
Assalamu alaikum and good morning, ladies and gentlemen. Soft cataract, this is, everyone will bear me out. There is a constantly increasing trend of soft cataract surgery. And many times we are stuck up with the soft cataract because sometimes quite tenacious. And it tries to jump in the phaco-tip suddenly, and then we may be in trouble. So I've invented, and I'm practicing this technique. I just presented this in the SARC conference in Nepal almost 3 years ago, but that was an infancy. Now I'm using it on a regular basis, and I've found it very useful. And I strongly recommend this. Let's see what's this step. So in this, I first so on कैसे करना? You have the setting. उसके ऊपर एक पहले थे फर्स्ट पे Play करें इसमें. Yes. Now I give the settings of the epinucleus because they are mostly I'm using it for the soft cataract and doesn't take more than few seconds. And with the tip is slightly exposed more than the routine and the bevel facing towards the periphery of the nucleus. Next please. Now see is again if you remain on periphery it will be okay, otherwise if you go towards the center then you will be feeling little trouble. You see the probe has gone centrally and now it will hold the center and it will be there will be tumbling and then there will be slight difficulty. But you can use it anyway. This bevel should be towards the lens periphery. See again is soft cataract here. And same technique, slightly harder than the previous one, but it will not take more than few seconds. Yes. So it's very small time and very safe technique. Oh, this is same. This is same probably. Now first, in this technique, you first after doing capsular axis, you have to displace the lens into the anterior area, so capsular space, not directly into the anterior, and inject some viscoelastic underneath the cornea and some underneath the lens to push the posterior capsule backwards and to save the cornea. And then with the tip slightly more exposed than the normal and bevel towards the lens periphery, and the setting of higher vacuum and low power, you can do this. Now this is NS plus 2. This is slightly harder lens. Now in this case, you will see a larger nucleus. This is not very hard, but is quite large in size. And you can see the epinucleus and the nucleus, both rings, double ring you can see at the periphery. So in this may be a little difficult to get to the side of this, but with the practice you can easily do it. There was a jerk at the junction of endonucleus and the epinucleus. See, the nucleus is quite large and is slightly harder. It's NS plus 2 almost. Even then, it's very safe as compared to the conventional technique. And the last one. इस टेक्निक को ज़रूर आजमाएं और आप you will be very happy. I have never seen is striate in such cases. Usually the nuclei are very soft, and my follow-up is also after 10 days, on 10th day usually. So it's very rare. I always see a shining cornea after this. Thank you so much. Conclusion is very easy to learn and very safe. And the time is on almost 5 to 10 seconds at the maximum. Within 10 seconds, you can finish this job, mostly within 5 seconds. And I've done about 300 cases in 3 years, and in none of the cases I've seen any complication or any striate. Thank you so much. I would also like to continue with my next presentation. Ijaz Latif 2 लिखा होगा उसमें. Because I have to run back to.
So Dr. Ijaz Latif, Professor Ijaz Latif has described windmill technique beautifully. This is known as windmill emulsification of the nucleus. आप उसको घुमा देते हैं फेको करंट की मदद से और साइड से ले लेते हैं. It's a very quick procedure. The only problem is that you have to bring it into the anterior chamber first. And as he depicted, use the hydrodissection and hydrodelineation followed by viscodelineation to prolapse it into the anterior chamber. And then always respect the corneal endothelium and be aware that we have to cushion it with viscoelastic, because working with phaco in anterior chamber is always poses a little bit more risk to corneal endothelium.
Yes.
Assalamu alaikum. I want to share my experience. I am doing same technique for the last 7 to 8 years, but I am doing it within the bag because of fear of touching the endothelium and endothelial
Then
loss.
the fear of piercing the bag is more.
But the message should for the audience should be that be careful. If the endothelium you feel that striate is in post-op, then you can do it within the bag.
I am using it in the soft cataract and I have never seen a striate. आपके सामने ही है 3, 4, 5 सेकंड में सारे केसेस आपने. ये मेरे अर्लीस्ट केसेस हैं. तो ये जो मैंने बहुत पहले ये प्रेजेंटेशन सेम है जो मैंने आपसे 2 साल या 2.5 साल पहले दी थी सार्क में. तो अभी मैं पाकिस्तान में अभी मैं इसको स्ट्रांगली रिकमेंड करता हूँ. बाकी आप ज़ाहिर है हर एक की अपनी चॉइस है. हार्ड कैटेट के लिए सही नहीं है. और विद इन द कैप्सूल बैग यू विल टच द कैप्सूल बैग. Posterior, you can go because these are very soft catered and they suddenly jump into your phaco tip and then there may be a slight surge and you can hit the posterior capsule. So be careful while using steps.
Actually, the soft cataract, you do it within the bag or you prolapse it a little bit. Many surgeons prolapse it half because then you can avoid cracking. So it is actually a matter of aspiration only. Because it's soft, you don't need much phaco energy. So do it the way you like to do, but remember that the too soft and too hard are not the cataracts for beginners. You need a little experience and you need a little training before attempting too soft and too hard cataracts. Too soft is easy to aspirate. You don't need to spend much phaco energy on it, but you need to be well trained with use of your feet. To what extent you want to use phaco energy. So that's a lesson. We have to protect two structures mainly, the posterior capsule and the corneal endothelium. And even if I have to choose between the two, I have to choose corneal endothelium because there are certain replacements and managements for the posterior capsule, but from where we will bring the corneal endothelium back. So corneal endothelium is the most important structure in anterior segment, which is irreplaceable. So we have to respect that. Please proceed with your next presentation, sir.
Thank you so much. My next presentation is about the subluxated lens. I have done this was same, almost exactly same subluxation in both eyes, and I've done it in both eyes of the patient, not simultaneously, but with some. So. This is not a soft cataract, but is subluxated hard cataract nucleus sclerosis was +3. So click. वो इसको एनेबल कर दें वहाँ से. Yes, just after making a radial cut and a circumferential flap just at the start of the flap, just turning it circumferentially, and I usually like to insert my CTR at this stage in soft cataracts where we don't need hydrodissection. Just so you can see is huge subluxation. You can't see the zonule here. You can see the equator of the lens is from almost from 3 to 9 o'clock position. You can see the equator. There is no sport, but here is good sport here. ये बस इसमें आपको we have to stop breathing for a couple of minutes. जैसे मजरी साहब फरमाते हैं ना कि आँख से चोरी हम मोतिया चुरा लेते हैं, तो चुराने वाली बात ही होती है ऐसे केसेस में कि अगर आँख को पता चल गया कि हम अंदर हैं तो फिर वो कभी आपको अलाउ नहीं करेगी, इधर भी सब कॉम्प्लिकेशन भगदड़ मच जाएगी.
Then
So
I will
इसलिए
take you. Then I will take you in.
First it will fight and then it will react.
yeah. So now after this I'm going to complete this because there was no sport. While I'm pulling downwards, there is sport of the zonules from above. But yeah. Yeah. We sometimes I take the help because where I think that I might be able to do. But usually what I present from the very beginning, from 20 years when we were in starting in Alhambra Art Council, उस वक्त से जब VCR पे रिकॉर्डिंग करके भी मैं वही चीज़ प्रेजेंट करता था जो सब लोग कर सकते हैं अपने क्लिनिक में विदाउट एनी एड. तो अभी मैं प्रैक्टिकल सोल्यूशन आपको बताता हूँ, जो भी आपकी डिफ़िकल्टीज हमारी होती हैं उनको जो प्रैक्टिकली कैसे हैंडल करना है विदाउट अदर सोफिस्टिकेटेड गैजेट्स जो हमारे. Yeah. No, see, and sometimes the CTR will prolapse into the sulcus then. वो उसकी अपनी कॉम्प्लिकेशन है, बस इसमें मैं आपको बता रहा हूँ जो मेरा एक्सपीरियंस है वो मैं शेयर कर रहा हूँ एक्चुअली. सो आई डिस्प्लेस्ड इट although it was slightly harder cataract, it was NS+3, but I had to use this technique very safely because there was no sport of the capsule. So अगर इसी को मैं नीचे उसको करने की कोशिश करता तो हो सकता है डिजास्टर हो, बट see very easily. So you can apply this technique in such cases where there is subluxation, gross subluxation.
A comment, sorry.
Thank you so much.
If the subluxation is traumatic, the rest of the capsule is quite tightly adherent to the ciliary body. In case of congenital and malformed capsule and pseudosphulation, then there is a problem, then it should not be done. Thank you.
Yeah. This मंजर खूबसूरत है, no doubt. So what happened? This is a two-step technique because now I'm trying to remove the cortex, but the cortex gone over the CTR and the fibers are coming from anterior side and going to the posterior side on top of the ring. So they are not giving way. I'm trying my best to take it out with the Simcoe cannula very, very slowly, because I can't exert force. So I'm going very, very slow, whatever is possible, but I'm not able to do it with the, because you can see the ring which is moving and it may perhaps it may come out. So I've left it for a couple of days on my next test, on the alternate day. So I just stopped it here. जो पॉसिबल एफर्ट थी वो मैंने की है, लेकिन ये कि आप यू कैन सी द रिंग Coming down.
Because of the CTR, you are not able to take the lens matter out easily. So it's better to, the rule of thumb for CTR is implant it as late as possible, but not too late.
Yes.
So it depends on the convenience of the surgeon.
After 2 days, the cortex has become very soft and I can easily take it out after 48 hours. It's almost exactly after 48 hours. I am doing my list on alternate days, so on the next list, I did it.
The ideal recommendation on which the international ophthalmology community agrees is to complete the rhexis with the help of capsular hooks and then perform the hydrodissection and try to aspirate and clean the lens bag and then implant the CTR. But if it is good in Professor Ejaz's hands, he is welcome to do that. But I am just telling you the recommendations. I am not denying his technique. But the international consensus for the beginners is that complete the rhexis with the help of the capsule hooks, keep on stabilizing it wherever there are weak granules, and after completing the rhexis, perform the hydrodissection at least, try to hydrodelineate the nucleus, and try to aspirate it if possible. And if you do all these steps, and then apply the CTR in case of soft cataract. And even in case of hard cataract, use as many hooks as you like. But try to finish the phaco part.
मेरी कमेंट इस पे भी आपने कमेंट्री करनी थी
hooks, not with the CTR inside.
अभी इसको रिवर्स करके बताऊं कि क्या क्या कर रहे तुम्हें. चलें कोई नहीं. आपका टाइम पहले शॉर्ट है. So अच्छा, थैंक यू सो मच लेडीज एंड जेंटलमैन. मदरी साहब से फिर हमारी हमेशा जब मैं स्टेज पे होता हूँ तो मदरी साहब नहीं मुझे छोड़ते और नीचे मैं नहीं इनको छोड़ता ना. तो ओके सर, थैंक यू सो मच. कोई क्वेश्चन आपने करना हो तो इस वक्त भी कर सकते हैं.
Dr. Nasir, you want to say something? Please come to the mic in the center.
It was indeed a perfectly planned and operated patient. And I just would like to agree with you, because in my own practice, I usually use iris hooks, because it was this distance was extending from 11 to almost 7 o'clock. So 2 iris hooks at the margin of rhexis would have made the things quite easier. I love to use iris hooks in these sort of distance. And the things in case of implanting CTR, removing the lens matter, implanting the IOL, it becomes really quite easier, because he is, mashallah, experienced hand. So that's not a problem with him, but the things certainly becomes easy with the use of iris.
That is the guideline. That is the international guidelines. Thank you. आपकी बारी भी सर आ गई है, आप ऊपर ही आ जाए.
I think surgeon preference is very important.
That's right.
Yeah.
He can see the situation, he can see the circumstances. He is the person who can use CTR or hooks. He is the best person for the best care of his patient. Thank you.
Thank you so much.
Thank you, Dr. Ijaz Latif.
Sir,
thank you very much indeed. Now I will request Professor Tayyib to come over the dais and present.
You can say whatever you like.
Sir, one of the point that I want to discuss is in all these techniques, when we tilt the tip of the phaco, the one eye of the sleeve is directed toward the cornea, while other eye is directed toward the PC. I think it would put some stress on the endothelium as well. Would not it be safe if we turn the sleeve sideways, so that both of the sleeves, they are directing toward the iris?
Actually, this steam, the jet, the steam doesn't damage the endothelium if you have placed viscoelastic. And if you have placed viscoelastic just before doing this technique, behind it will keep the capsule pushed And this the second thing which we achieve from this, that this flow, when you tilt your sleeve like this, the flow is coming from up and down, it's going this way, and it's helping rotating and accelerating on the other side. So that's why I say that we have to expose more, the tip slightly more as compared to the normal, which we keep, because we want that the push of the fluid should not be there, and it should be backwards and come from the front. So there is a circle form here, and it keeps the posterior capsule pushed backwards. It will not damage the posterior capsule at all. And this is my personal experience. That's why I was not recommending it first, but after 300 cases, I'm seeing the safety of this technique, 100% safety. Then I'm telling you that you will find shining cornea instead of doing this in the capsular bag. As compared to that, you will find less time, very easy, no complication. In soft cataract, we do get complications sometimes, and it jumps into the phaco tip, and we touch the posterior capsule or the fornix of the capsule, and it's very difficult sometimes to take out from the fornix, capsular fornix. So you'll try this one, and you will be happy, hopefully.
Thank you, Professor Ijaz Latif. Dr. Tayyab here for precedent management in posterior polar cataract and iridodialysis repair.
Posterior polar cataract is a challenging problem for the ophthalmologist. It looks very innocent, but at the end of the day, at times it behaved in a strange way. In 20 to 25% cases, there are chances of posterior capsular rupture. Usually, it is very important to diagnose pre-operatively. If it's a cone like a concentric ring, it's usually posterior polar cataract. If it's flat, it's posterior subcapsular. Another most important thing is discussion and counseling of the patient. Discuss him with the detail. I may not be able to implant the IOL, or your lens may fall in the vitreous cavity. This patient is a young patient, 45 years old lady. In such patient, capsulorrhexis is a bit difficult to perform. Another important thing is there should be an adequate size of the capsulorrhexis. Now I made a mistake here. I'm trying to do the hydrodelineation. Unfortunately, I performed hydrodissection, which should be avoided at any cost. Now I'm debulking the nucleus. I'm very gentle. Your parameters, phacoemulsification parameter is on lower side, lower vacuum, lower irrigation, lower aspiration to avoid posterior capsular rupture. I'm gently removing the nucleus. Now, this is the moment. There is a rupture in the posterior capsule. Now what to do? We can share our experience so that end of the day we can take care of our patient in a better way. I did bimanual anterior vitrectomy. Usually I place the cutter in the center of the nucleus, posterior to the irrigation line, and doing anterior vitrectomy. It's always better to remove all the vitreous in the anterior chamber. changing the port, removing the subenthesional cortex, viscoelastic injection. And, usually there is a recommendation you should implant multi-piece IOL in such cases. I decided to implant single piece lens and I performed posterior capsular capture. After inserting the haptics in the sulcus, I captured the optic behind the anterior capsulotomy. The removal of the ocular viscoelastic device. You can appreciate the posterior capsule capture of the optic of the IOL. Thank you very much.
Thank you. तो ये सब एक question है इसमें कि in such a situation while implanting the lens, in which case you select, you should go for multi-piece, and in which case for single piece.
Again,
what are the criteria to select?
Again, I would like to say it's a personal preferences of the surgeon. If a bigger size of the capsular axis, it's better to go for multi-piece IOL. If you have an appropriate size of the capsular axis, you are sure enough you can posterior capture of the optic portion, then you can have single piece IOL as well.
Actually, the reason people avoid this single piece is that it is 12 millimeter and multi-piece is 13 millimeter, and that gets fixed in the bag, in the sulcus. While the single piece, that it's a bit mobile, whichever the lens may be, and that can continuously initiate low-grade inflammation.
I agree, but if you can perform capture of the optical portion of the IOL, then there is a less chances of rotation of the IOL. Yes. If you implant a single piece in the lens, in the sulcus, then it keep on rotating. Yes. Then it's not advisable to use a single piece. Then you can implant multi-piece, which has a bigger overall diameter of 13 millimeter of mercury.
Thank you, thank you. Next.
Sir, I would like to ask a question. Sir, is it okay to place my hydrophobic acrylic lens in the sulcus? The haptics can be placed in the sulcus? Because I thought it caused UGH syndrome if we placed hydrophobic acrylic lens in the sulcus.
I implanted hydrophobic or hydrophilic?
Hydrophilic. Okay. My mistake. Thank you, sir.
The next. अब रेस्पॉन्ड कर रहे हैं इनको?
He understood my answer.
बात हो गई है ना वो. इनका पॉइंट ये है सर, पॉइंट ये है कि हाइड्रोफोबिक या स्क्वायर एज लेंस जो होते हैं दे कैन कॉज मोर शेफिंग, वो उनका पॉइंट है.
I have no experience.
चल नेक्स्ट सर, आप नेक्स्ट प्रेजेंट आपकी वीडियो.
It's actually
आपकी और भी वीडियो है सर?
वो जब आएगी तो चलो कर दे प्ले.
Iridodialysis
was consist of two. First portion I did, the other second half was done by Dr. Hamza. I will comment on my part.
Please go.
Dr. Hamza, can I come forward?
Hamza आप आ जाएं.
Please play the video.
So father and son join hands in next presentation. Hamza Ali Tayyib and Dr. Tayyib.
Thank you very much. I have no.
Hamza has 3 presentations.
This is a 22-year male, photophobia, It's a traumatic hydrodialysis, 180 degree. The purpose of operating was the photophobia, not visual loss. It was done 10 to 12 years back. It was my first case. And this is the iridodialysis. I applied iris hook to create the nucleus, to create the pupil, because it was totally updrawn. Capsulorhexis iridodialysis repair. This part of the there was a this was my first case, just a 10-0 nylon stitch. In those days, special suture with straight needle was not available. I decided to improvise with a curved needle. After doing phacoemulsification and implanting IOL, I repaired the iridodialysis. Keep on injecting OBD in the anterior. Can you go forward? आगे कर दिया. Followed by needle externalized keratotomy. और कर दो. The stitch loop was externalized through this localized keratotomy.
Assalamu alaikum.
This is the end of my case.
So in the previous video, the iris repair was done by a curved needle, and this was. Rest of the iris is missing. I'm going to use 10-0 proline suture to tie the iris to the spiral spur. This is a 26 gauge needle, which I pass through the partial thickness incision that I have made. I'm unsuccessful on my first attempt, and now here, as you can see, I'm successful to the suture. It is easier to thread the needle if you bring the 26 gauge needle closer to the paracentesis.
This was RL Daysen's after complicated cataract surgery.
The long straight needle attached to the 10-0 proline to the partial thickness. Yes.
This is a double arm
10-0
proline straight needle.
This is a double arm suture, a double arm 10-0 needle. So the two needles pass through the same paracentesis. They are threaded into the 26 gauge needle, and here, as you can see, there are two parallel threads and a loop which will be pulled into the eye and push the iris towards the spiral spur. The two parallel threads are of the two parallel needles which we passed earlier. Here, look at the iris now. It's been pushed towards the. You can see the loop entering into the paracentesis, and here you can see now.
Tied the iris superiorly because
the defect which was
the patient was experiencing a lot of photophobia. So should I continue with my?
Yes.
Assalamu alaikum. Today I am going to discuss a case of a post PPV cataract.
This was a vitrectomized eye.
The corneal opacity with the iris defect. This patient had an intraocular foreign body which was removed by the pars plana vitrectomy.
In this case, I have to be careful and see if the anterior and posterior capsules are intact. This is a young 24-year-old man, and the anterior capsule seems intact. Now I have to do very careful hydrodissection. The nucleus rotates, which is a positive sign and shows that most probably the posterior capsule is intact. I do not want to stress the capsular bag too much, as I am still not sure if the posterior capsule is intact. And here, as you can see, the posterior capsule is intact. However, it is fibrosed. Now fill up the capsular bag with a very small amount of viscoelastic. I plan to do a posterior capsulorhexis to remove the fibrotic plaque. I use a 24 gauge needle and puncture a hole in the posterior capsule. Now I'm going to use the utrata forceps to make this hole into a posterior capsulorhexis, encompassing the opacities on the posterior capsule. I try to hold the posterior capsule, however, since the posterior capsule is just about 2.5 micrometer in thickness, it is proving quite difficult. As the patient has already undergone a vitrectomy procedure, I am not afraid that vitreous will come forward here. As you can see, I am successful in making a flap on one side. I try to pull on it, however, it breaks. I have to be careful not to pull too much. As I turn over the flap and finally I am able to get a plane here. I'm finally able to turn the rhexis. This is requiring a lot of effort, and I'm careful not to cause dehiscence. Now I grab the other aspect, the other side of the flap, and then I will rotate it in the opposite direction. And here it's done. I've made a continuous curvilinear posterior rhexis. Now I plan to do
due to the unavailability
an
of
optic
multi-piece
capture,
I
place
would
the
like to
lens in
implant
the
a hard lens.
sulcus, and here you will be able to appreciate the margins of both the anterior and posterior rhexis. Here I am placing the haptic in the sulcus, and now I am successful in achieving optic capture. You can see the margins of the posterior axis, the anterior axis, and the optic capture. Thank you so much for watching. Hope you found this video helpful. Please comment and give suggestions. Jazakallah.
So 24 years old. Yes, so that's you can do YAG if you want, but because the patient was vitrectomized, so there was no danger of any pull on the vitreous. So we could do a posterior rhexis at that time instead of. Yes, that was also an option.
Dr. Hamza, you did an excellent job, but my own personal preference would have been that IUL should have been placed in the bag and I may have gone for YAG because of the age of the patient. But this is a beautiful technique to depict. If it is a pediatric age, then you can do whatever you like. And the second thing is that I always, when I am talking about pediatric cataract, I always promote that implant the IUL first. And then you can perform the posterior axis behind the IUL.
You are safe.
Because it is always difficult with both axes in place and then implant the IUL in the bag. It sometimes becomes tricky. So, but mashallah, Hamza did a beautiful surgery and he had his preference to perform a primary axis. He did that, but the ideal scenario in this case, as you have commented, would have been to implant the lens in the bag and perform a YAG later on.
I will differ a bit. I will go in favor of him because if you do YAG, you leave those fragments within the vitreous and they will cause problem. They may do some inflammation and they will floaters to the patient. He is a young person. It is better if you can do and remove all this stuff out. Thank you. Dr. Homa wanted to comment. Yeah.
Thank you, madam.
The next presentation.
और भी है?
Have you आपकी?
Yes, sir.
Please go ahead.
So, case of a CTR adjustment that I did.
This was a dislocated bag IOL complex.
This patient came to me with the dislocated IOL with CTR and dislocated bag. So I've decided to fixate the CTR to the sclera and inferiorly. The patient who had been rendered aphakic, partially aphakic due to the subluxated lens. So I decided to take up this case. I make a small partial thickness scleral groove 2 mm from the limbus where I plan to bury the knot of the suture which will be tied to the CTR. I make a paracentesis 180 degrees opposite to the scleral incision that I've made, the scleral groove that I've made, and now I fill up the anterior chamber with a dispersive viscoelastic. Now I take a 26 gauge needle I will pass this 26 gauge needle behind the iris. I have to make a small puncture in the capsular equator. However, since the bag is fibrosed, I'm not afraid of tearing it. This 26 gauge needle is actually beneath the capsular axis. Take a 10-0 straight needle, 10-0 proline straight needle, and please observe the direction of the bevel of the 10-0 needle. If the bevel is sideways, it will be difficult to thread the needle into the 26 gauge needle bore. Now I have changed the direction of the 10-0 straight needle, and please observe that it is most easily threaded into the 26 gauge needle when the bevel is downwards, the bevel of the 10-0 straight needle. If the bevel is sideways, it will be difficult to thread into the 26 gauge needle.
Suture.
So I pass one thread behind the CTR, and my plan is to pass another thread of this double arm 10-0 proline suture above the CTR so that it can pull the CTR inferiorly. Now please observe that the blood at the paracentesis is hindering my view.
so it will be difficult to pass the 10-0 needle through it. This will have consequences in the surgery which will result in this 10 minutes surgery being extended to 30 minutes. As you will see later on in this video. Now I pass the 26 gauge needle above the CTR and I take the 10-0 needle and I pass it through the paracentesis a little bit blindly, and at this point I do not note the mistake I've made. I thread it carefully, turn it down the bevel, thread it into the, I'm facing difficulty because the bevel is not downwards. However, I am successful in threading the 26 gauge needle with the 10-0 straight needle, and now please observe as I pull the loop here, I have accidentally, the second 10-0 needle accidentally took a bite of the corneal stroma, and now the loop is stuck in the corneal stroma. However, I have now cut them and I pull them, and I decide to pass a fresh double arm suture, and as I pull on both the loops, please note the loop passing through and here. Now I breathe a sigh of relief. I tie the two ends of the double arm needle after cutting the needle.
So
after
it
adjustment,
would have been better if I had
I
tied
have to
them a
make
little
sure
bit
that I do
temporarily.
not tie them too tightly because
for better
it might tear
centration.
the capsular bag. However, the lens capsular complex is now partially centered,
There is also a post-operative picture.
and I also have a post-operative picture of this young patient. He was a
So if
24-year-old male, and he
complex has been tied a little bit temporarily, it would have caused a better centration.
Good.
Dr. Hamza, what was the age of this patient?
Sir, I think he was also a young male. I don't exactly remember the
And
age.
what is the nature of this dislocation?
I think it was due to a congenital cause. He had surgery done many years back, and everything had been displaced.
Then there is a word of caution. You
Yes,
should have fixated the other side as well, because it's a progressive condition. I
Yes.
always see in the net and advocate that there are two things in subluxations of the pseudophacos or subluxation of the crystalline lens itself. One thing you need to classify and know exactly is severity of the subluxation. Mild, moderate, severe. 1 quadrant, 2 quadrants, or more than 2 quadrants. Second, nature of the subluxation, whether it's progressive or non-progressive. The traumatic subluxation will be non-progressive. So all the zonules of the other side, whatever remaining are there, will be available to the patient, the lens or the bag for support later on. But it's if it is a progressive condition like Marfanoid syndrome or like pseudoexfoliation syndrome, then it's always wiser to fixate both sides, because very soon the other side will give way because of the progressive nature of the problem. But the job done by you was excellent. In situ repositioning of the IUL bag complex with tension ring, the technique is what is recommended and is copyable. But my recommendation is that one should take care of the other side as well, knowing the progressive nature of the disease.
So this is my last presentation on phacoemulsification in a microcornea patient.
millimeters. This is a unique eye. The tunnel length of the main incision
So it had an 8 millimeter
should
corneal
be
diameter
shorter, as you will see
and
later
I
on in the surgery.
made a slightly
It has
longer
been constructed
phacoincision.
keeping the corneal diameter of a normal eye in mind.
So because
Capsule is stained with trypan blue dye. It is washed out with
xylocaine and adrenaline. Intracameral HPMC is injected to form the chamber. Now look carefully. The chamber has become very deep after
Patient
injection
was
of the
there was a reverse pupillary block.
gel.
And the axial length was about 25
As
millimeter.
you can see, corneal striae are forming, and I have to orient the cystodome nearly vertically just to reach the anterior capsule. It's difficult to tear the capsule, so I switch over to a Utrata forceps. It is difficult to grab the flap of the rexus due to the deep anterior chamber. However, I am successful.
It was difficult to turn the
Capsule
rexus, and I
tends
was
to run
afraid that
in
the
the
rexus would
periphery.
run out in this eye, so I inadvertently made a smaller rexus.
A small capsular rexus is formed. In retrospect, I would have liked to make a larger rexus.
Since the
Careful
tunnel
dissection is done at multiple points, and the nucleus is dialed. Now you can see that there is
a longer tunnel,
length would be
so the
smaller
irrigation sleeve will
in these
continue to
cases because
block.
the irrigation sleeve of the phaco needle tends to get occluded in
So to avoid that, we can
the incision.
make a less
Thus,
exposure
there
of
is
the
always
phaco
a
needle.
fear of collapse of the chamber during phacoemulsification. There is a reverse pupil block because the patient is myopic. I use the dialer to lift the iris, therefore resulting in easy accessibility of the nucleus by the phaco needle. I try to perform a direct chop, however, as you can see, the irrigation sleeve continuously tends to slip out of the eye. Another thing that could have been done to prevent this complication is less exposure of the phaco needle, which would have resulted in the sleeve
Now I've
being
started to
placed
trench the
more inside
nucleus,
the eye.
debulk the central part of the
I
nucleus.
switched over to a trenching maneuver. I start to debulk the nucleus. I keep trenching at low volume.
If
at
you
low
bulk
vacuum.
the central part of the nucleus and then hold it from the periphery, there is less chance of the bag folding.
And finally, I am able to lollipop the nucleus out of the capsular bag. It's removed. And now, I use a simple cannula to pull the epinuclear shell into the anterior chamber. The bag is filled with viscoelastic, and here it is very important to inject the lens very carefully into the
Please
bag.
observe the
Make
size
sure
of the cornea and the
the
injector tip.
happens do not get stuck in the sulcus. The wounds are hydrated and the case is closed. Thank you.
Thank you.
So age becomes important
Age is very
in all
important.
of the Hamza's
So this
videos.
patient was in his mid 50s. He was an older patient. 25 millimeters. Yes, but it was myopic with a small cornea. Yes. Is normally smaller, but in this case it was larger, so it was a unique eye.
सर आप उधर माइक के सामने आए। तारफ भी करवाएं अपना सर।
Sir, I am Dr. Hanif. I am from Al Shifa Rawalpindi. If the axial length is short, like 1920, the power of the IUL might be above 30. I don't know what was the power of the IUL in this case. But in those cases, in hyperopic cases, life is very difficult after in cataract surgery. Bags are small, and to put the IUL in the bag, it will like, haptics will crumble and like this. I would suggest the companies to make small IULs for these patients. And if the axial length is good, like in your case, 25 or 26 millimeter, then the axial length is large, AC will be deep. So these cases, post-op, there will be no problem. But in hyperopic patients, there is every chance of glaucoma, pseudophakic glaucoma in these children. And we have suffered that. So that's my view.
So in the presently available IULs, one should try to choose the thinner lenses. The higher the refractive index of the lens, the thinner the lens becomes. So for such patients where the power goes plus minus 30, choose a lens with the higher refractive index and always find out from the companies that which company supplies the thinner lenses. For example, these Acrisoft and Hoya, they have high refractive index of more than about around 1.55 something. So they are thinner lenses. Then Zeiss has got few thinner lenses. So we should find out and we should consider this point while planning the shorter eyes. Dr. Hamza, is there any significance in this particular case that you stressed on the longer tunnel in cornea?
So because the sleeve because the cornea was small, the irrigating sleeve continued to get blocked by the stroma of the cornea because the tunnel was long. If the tunnel had been shorter, it would have
The tunnel should not be long.
It should not be long.
So that is the message. The tunnel should not be long in short corneas, but it should not be too short. The simple principle is try to get your incision in a square shape. The width of the incision should be equal to depth of the incision. That will facilitate your phaco and that will facilitate sealing at the end of the surgery. Thank you very much.
Thank you, sir.
Thank you.
Yes.
Thank you. Good hand for Dr. Hamza, showing excellent skill.
Dr. Hobakiani, आइए please. Removal of dropped lens and fixation with Yamani technique. Number 2, opaque IUL, how to go about it?
Okay, so my presentation is out of the ordinary, and it is a unique thing that not all of us see, but once in a while we might be seeing a case of intraocular lens opacification of eye. So bear with me, I didn't realize that this was just a video presentation. So we have a couple of slides, and then the video, one video probably will augment with the second one. So here we go. So this is what we sometimes notice. We notice a patient coming up with a lens, something like that. So if you haven't seen these kind of cases before, you might think that there's an anterior capsular phimosis, or you might even think there's a dense posterior capsular opacity. So as an introduction, it is not unique, it is not common. It can result in transparency of intraocular lens, and as such, it reduces the patient's visual acuity and contrast sensitivity. So diagnosis for juniors or for trainees and all that can be a challenge, because it is misdiagnosed as a posterior capsular opacification, which we can prompt easily as, let's take them for surgical procedures or even for YAG capsulotomy. So sometimes you might be going into the eye to doing a surgical posterior capsulotomy, and you'll be surprised that it has nothing to do with it. And then finally, it's important to think about it, and this intraocular lens has to be removed or exchanged, because leaving it behind will be a problem not just only for the patient but also for the surgeon. So I went into a lot of research to why does this intraocular lens opacification occurs? Why is it that some majority of the lenses are clear while few out of the blue turn white? So looking into the literature, there are acute intraoperative reasons and there are late onsets. So when we say intraoperative, it is defined as when the surgeon noticed the opacity is while during the surgery, IOL opaque ho raha hota hai. And this is because of either temperature fluctuations. Now in this part of the world, we do not have that much of a temperature difference, but let's look into the northern sides. So temperature fluctuation reports that immediate IOL clouding occurs while the intraocular lens implantation into the anterior chamber is probably due to storage conditions. Transferring the IOL from the outside temperature below freezing to the theater shortly before surgery is the common point of many reported studies, and sudden intraocular implantation into the eye with a temperature of 37 degrees centigrade in a hypothesized mechanism. This, if it's an intraocular, and because of the temperature difference, the opacity is transient and usually lasts for 24 hours with spontaneous resolutions. So both hydrophilic and hydrophobic acrylic lenses can be affected, but is more commonly seen in the hydrophilic ones. So, and then there is something which is known as imbibition of water. And in the imbibition of water, this is also because of the rapid temperature fluctuation which causes the water of the anterior chamber to get the intraocular lens sucks it in. And the recent study explained a possible cause in which increasing temperature may lead to microbubble formation, which releases air inside the IOL, causing light refraction, appearing as IOL clouding. Similarly, so what happened, they did it in vitro experimentation and they found out that this mechanism did occur. So advice, the IOL should be kept at room temperature before implantation, and especially and you must have noticed in winters that, when you're placing an intraocular lens into the eye, the haptics are, really stuck together and you have to do a little bit of manipulation before releasing them. And that's what the winter does. So this phenomena can almost always be spontaneously resolved with no permanent structural changes, and ophthalmologists should be aware of this nature. Now precipitations, IOL can have precipitations on them, and these are the calcium or phosphates precipitation within the lens or on the lens. Mechanism is unknown. Most common opacified lenses are hydrophilic in nature, and they can appear at any time, but most commonly in 14.93 to 17.82 months according to the analysis. So these crystallizations, it's always good to inject, put your intraocular lens in the injector right before you're about to inject. Don't do it before. Even your viscoelastic devices can cause these precipitations. And IOL implanting, like I said, should be done at that time. And injector should also, if the company you're getting your intraocular lens, it's always good to use their injectors or the recommended injectors. We over here are taking one injector and choosing another. There might be some precipitation there. There might be the viscoelastic that we're using reacts with the injector, and your intraocular lens is there, and it can cause that. So if you have to look for intraocular opacification, I had this IOL and I sent it everywhere for light microscopy, and it was so surprising that in Lahore, I don't know about other places, in Lahore there was no place available where I could get to find out why did my intraocular lens, why this intraocular lens got opaque. But recommended books say that electron microscopy and X-ray photon electron spectroscopy can help you look at this in the form of calcium deposits. IOL discoloration has been reported with povidone iodine. Now that was something that was a surprise for me. So povidone iodine should not be instilled at the end of the surgery, because inadvertent leakage could lead to the entrance of this toxic chemical into the anterior chamber. Early postoperative intraocular lenses, I will just rush manufacturing defects, changing hydrophilicity, and the rest of these. So risk factors, anybody who's had one of these are more prone to developing IOL opacifications, and it is more seen in hydrophilics. Now these are the ones that you and I will see. We hardly see ones that are intraoperative, but late, yes. And then these are usually in years' time. So adequate resolution of this type of clouding, if you think that this IOL clouding is going to go away, you're sadly mistaken. So you need to do an IOL exchange. So this is how we, if it's if you find out the clouding early, you can do it early and maybe you can exchange it. But the problem is that by the time you see it, these lenses, the acrophilic lenses, are adherent to the anterior and the posterior capsule, and it is very difficult to salvage this eye. So this is the case that I saw. This surgery was done somewhere in the district, and the patient said that I had started having intraocular lens opacification within a few months. And this is a 7-year presence of an intraocular lens looking like this. So imagine I tried, my God, I tried my best to release the capsule, release the haptics, release anything that I could, but it took me literally hour, but I couldn't do it. So at the end I was disheartened, and then I thought, rather than manipulation, I have to take the whole of the capsular bag out. But I did not want to damage or open up the cornea, the paracentesis, or enlarge it just a little bit more. So manipulation was done to the point, keeping in mind that I'm going to do a scale fixation intraocular lens later on. And so the first thing was to remove it, bring the bag forward, and then, because I don't want to take it out from this I don't want to extend it, so I started cutting the intraocular lens. This looks easy. It's not. It needs practice, and it needs a lot of sweat, and practically I was sweating, and I was so worried that I am going to lose this capsular bag and it is going to fall back. So, am I the last presenter, Ajit sir?
आप करें अपनी presentation.
बस नहीं मैं से पूछूं, because फिर if because of shortage of time I might leave the other one. अगर time short है ना तो अगला छोड़ देंगे, अगली presentation को. So you can cut them slow and steadily. Just cut the intraocular lens out and then squeeze it out from your paracentesis port. आप यहाँ पे stop कर दीजिए जी. Thank you. So that's about it. And दूसरे की है time कि we can just we can ignore it also.
Next हो जाने दे, उसके बाद time है तो आप आ जाएं.
जी हाँ बस ठीक है. Last you can. This is good. Thank you so much.
It was an excellent presentation. We frequently come across, not frequently, but
thank you, Dr. Kumar, for demonstrating your excellent technique. Recently, I also came across multiple cases of opaque IOL. My request to my colleague is, please use branded IOL. Don't compromise on the quality of the intraocular lenses. Thank you very much.
I fully endorse your point, sir. Thank you. Because these lenses have tendency to go white. Dr. Nasir Chaudhary is here.
Bismillahirrahmanirrahim. This is indeed great pleasure to be here with all of you. And I have to talk about phaco in small people. And believe you me, phaco in small people really becomes Bermuda's Triangle, which still remains the unsolved mystery. And because you are aware, because in a small pupil, when you are going to operate a patient with small pupil, it can end up with a iris tear. And because of small pupil, it can obscure your views throughout the surgical procedure. You can end up with a disaster in the form of nucleus drop. So the diameter of the small pupil varies according to the expertise and skill of the surgeon. For an expert or for a experienced people, it might, even 1 millimeter can be an appropriate size to operate. And for a novice, it may be from 4 to 4.5 can be a remarkable area where he has to operate. So, as we know, Pakistan is at number 3rd with the more diabetic population. So, we have to experience small people in large number of patients. In patients with uveitis, pseudoexfoliation, and so many other patients, like the people who are using TEM solution, which present in the form of IFIS, intraoperative floppy iris syndrome. So we have to face a lot of challenges in case of small pupil, risk of iris damage leading to iris bleeding, and in later stage it can end up with the secondary glaucoma as well. During surgery, you can have problem with the iris. These are the few techniques we can use while operating in a patient with small pupil. It can be either due to posterior scenics extending throughout 360 degree or a membrane just stretching across the pupil in the form of occlusio papillae. So what should be our strategy? So the two things are very important. We have to differentiate because there are two types of mainly small pupil.
Please run the video. We are short of time. We are very short of time.
So we have to differentiate the elastic pupil from the rigid pupil. Elastic pupil usually present in the form of intraoperative floppy iris syndrome. And we can differentiate elastic pupil from the rigid pupil in two ways. We can inject BSS, and the rigid pupil will hardly enlarge with the BSS. While the floppy iris, it will enlarge and momentarily it will come back. In the meantime, you can use viscoelastic, and intraoperative floppy iris syndrome will immediately come back after injecting your viscoelastic, and it does have tendency to prolapse through the your phaco bone. While going for surgical intervention in these small people, the people can use different techniques. Like I used, even we can use two dialers to stretch the pupil. I stretch it in one plane, but many people can stretch it in two different planes to dilate in a appropriate size. And then after dilating the pupil, you can peel away the peripupillary membrane. And after that, I thought it was an appropriate size to for a rhexis. And because this was not a much harder cataract, so I got it a bit lifted. And but normally in my routine, I never use any additives like iris hooks or other expanders. I use phaco-chop with different fluid parameters, and try to remain in the center of the pupil, and try to manage it as early as possible, so as to avoid touching the iris, and avoid to damage posterior capsule, so as to avoid the complications. So many people can use different like intracameral mediatics, viscodilatation, posterior sonicolysis. This is very commonly used in our operation theaters with small pupils.
Thank you, Nasir. बहुत अच्छा बात बताया. One point. If you don't use hooks or things like that, and you anteriorize the nucleus into the anterior chamber, and you do the surgery, one thing for the high volume surgery, where as in your hospital, always use good viscoelastic, dispersive viscoelastic in front of the lens, and keep the your endothelium. That is the most sacred element, as damage would likely to occur in this type of surgery. So always use that viscoelastic.
Yes, very rightly said, sir. और जैसा कि अगर कोई और क्वेश्चन हो तो दिस विल बी प्लेजर टू आंसर. जो रिजिड पीपल हैं वो बड़े शरीफाना तरीके से बिहेव करते हैं. वो आराम से उसमें बड़े आराम से, अगर आप इफ़ यू आर कॉम्पिटेंट इनफ, तो आप यू शुड रिमेन इन द सेंटर ऑफ द पीपल विद स्टैंडर्ड फ्लूइडिक्स. तो उसमें ये कि आपको इवन आयरस टचिंग और फिर द कॉम्प्लिकेशन रिलेटेड विद द जो पीसी रेंट, वो इट बिकम्स रिलेटिवली स्मॉल. जो आपको तंग करता है वो दैट इज़ IFIS, इंट्राऑपरेटिव फ्लॉपी आयरिस सिंड्रोम, जो कि हमारी पॉपुलेशन में जैसे BPH के पेशेंट जो टर्म सोल्यूशन लेते हैं, या इवन हाइपरटेंशन के साथ, एज के साथ, जेंडर के साथ, अल्फा-1 एडिनर्जिक एगोनिस्ट जो है फिनेस्ट्राइड वगैरह, उन पेशेंट्स में इसका फ्लॉपी आयरिस का इंसिडेंस बढ़ जाता है. तो दैट इज़ बेसिकली यू हैव टू बी इन कंसर्न वाइल डीलिंग विद फ्लॉपी आयरिस. तो उसमें समटाइम्स ये है कि यू हैव टू यूज़ आयरिस हुक्स. तो वो दे आर कॉमनली अवेलेबल इन आवर पार्ट ऑफ द वर्ल्ड. बाकी जो फैंसी इस तरह की जो आपके पास दैट नॉर्मली कास्ट अराउंड $175 to $200, तो इस दैट इज़ नॉट पॉसिबल जब हम इतने मैथ लेवल पे स्पेशली इन पब्लिक सेक्टर हॉस्पिटल में या चैरिटेबल इंस्टीट्यूशन में कर रहे होते हैं. तो विद योर एक्सपर्टीज इफ़ यू आर इन द सेंटर ऑफ द पीपल, आप अपने जैसे अब जो आर्टरी जो है बहुत सारे जो सेंटर्स पे यूज़ हो रही है, तो उसमें एक स्पीड मोड है, तो उसमें ये कि आपका वैक्यूम कंट्रोल रहता है, तो दैट इज़ अ वेरी लेस चांस कि आप आयरस को एंगेज करें या पीसी को रेंट होने का या पोस्ट सर्ज ओक्लूजन जो है उसका रिस्क रिलेटिवली कम हो जाता है. थैंक यू वेरी मच.
थैंक यू वेरी मच. थैंक यू डॉक्टर नासिर. नाउ लास्ट प्रेजेंटर डॉक्टर ज़ियाउल बज़री.
सर अगर हॉनेस्टली स्पीकिंग कि अगर कोई इसमें प्री एग्जिस्टिंग ग्लाकोमा या अगर कोई ऐसा यूविएटस में ज़ाहिर है ऑफ कोर्स देयर इज़ अ रिस्क ऑफ ग्लाकोमा एज वेल, तो मैं आमतौर पे अवॉइड करता हूँ. लेकिन ज़ाहिर कि अगर ग्लाकोमा का पेशेंट है, यूविएटस उसका चल रहा है, तो उसमें फिर ज़ाहिर दैट विल बी प्रेफर्ड चॉइस.
In this video presentation, innovative plug-assisted haptic tucking technique is explained. The first case is a phakia with corneal scar and missing capsule. The PPP has been performed. And as you can see, we are just identifying and marking the tucking sites 180 degrees apart, 1 millimeter posterior to the limbus. And the neck is performed with 11-0 blade at the tucking site for better placement of the punctal head. Then comes the punctal plug in the picture, and 30 gauge insulin syringe needle is being used to pierce the punctal neck, and thus it will be used to thread the IOL haptic and push the threaded punctum over the IOL haptic like iris hook locks. See, this is how it is threaded, and this is a trocar assisted entry into the tucking site, and the anterior chamber maintainer is inserted, and 3.2 millimeter incision is performed at the steeper meridian. The endothelium is given a cushion with the viscoelastic. Then the IOL is carefully folded, and forceps assisted delivery into the anterior chamber is being performed, and Sinski hook is used to place it behind the iris. Then the ILM forceps goes through the inferior tucking site, and Sinski hook helps to feed the ILM forceps the punctal plug, and the punctal head is thus externalized through the tucking site and gently positioned. The similar procedure is repeated with the other IOL haptic, and punctal plug is threaded, and the IOLM forceps goes through the superior tucking site, and the Sinski hook helps to place the threaded IOL haptic behind the iris, and here the forceps grabs the punctal head, and with gentle pressure it is externalized on the superior tucking site as well. So both the haptics are thus fixated with the help of the punctal plugs. The wound is hydrated and the incision closed. The second case was secondary IOL after a complicated phaco, and as you can see, the again 30 gauge needle is being used, but this time the punctal plug has been tied with 80 vicryl suture. So instead of externalizing the punctum directly, we will use this 80 vicryl suture to feed to the IOLM forceps, which will be quite easy, as you can notice. So once this neck of the punctum is tied securely with the 80 vicryl suture, the punctum is removed, and then a similar technique as you noticed in previous video is used to thread the punctum over the IOL haptic, and MBR blade 23 gauge is used to prepare to 23 gauge entries at tucking sites. The IOL incision is made and McPherson forceps feeds the tied 80 vicryl suture to the IOLM forceps, and it very easily and smoothly the suture is retrieved. The other end of the suture is attached to the punctal plug neck, and gentle traction on the suture also helps the intraocular delivery of the intraocular lens. The lens is placed carefully and gently anterior to the iris, and care is exercised so that the plug does not dislocate. And then the Sinskey hook takes the eye, places the IOL haptic back, and a gentle traction on the 80 vicryl suture externalizes the punctal head through the tucking site. And similarly, the IOLM forceps is used to externalize the vicryl suture from the other tucking site, and this time the traction on that suture brings the head out on that place as well. So the IOL is well centered, the wound is hydrated, and the incision closed. 9 months post-op, well centered IOL, and you can very well notice the punctal heads, superior and inferior, with round pupil. Punctal assisted haptic tucking appears viable option, but further studies are recommended. Thank you for your attention.
Thank you, Dr. Mazari, and thank you everybody for excellent presentation and giving comments and advice to the surgeons as well to the audience. It was the last session, and Alhamdulillah, it has gone very well with your participation, and thank you very much everybody. Now, closing ceremony is in progress, and let us move to that. Thank you.